Thanks a lot, Antonio, and thanks a lot for waiting on me. I apologize, but I was giving talk on a different session. Uh, Hello, everyone. It is a great pleasure to share with you our clinical case. Uh, as Antonio already said, it will be about the use of novel, non-invasive medical device for assessment of left ventricular filling pressures in a patient with worsening heart failure due to severe aortic regurgitation. These are my potential conflicts of interest. And let's start with the patient. So it was an 83-year-old male who was in a single month hospitalized twice due to acute pulmonary edema. So really very symptomatic heart failure, initially with reduced ejection fraction, then developed into mildly reduced ejection fraction. And after these two quick hospitalizations, he came to my outpatient clinic. He was on standard therapy for heart failure, pretty standard comorbidities. And as I mentioned, he had severe aortic regurgitation, but due to the high age and other risk factors, the conventional surgery was contraindicated. When this patient was presented in my office, he was already compensated with mildly reduced ejection fraction. There was a decrease in NT-proBNP. We couldn't assess his left ventricular filling pressure due to severe valvular disease and also atrial fibrillation. But he was stable, so according to the guidelines, we reduced the furosemide doses. That's what guidelines advise us. If possible, go with furosemide as lowest as the patient tolerates. And I scheduled a follow-up in 2 months. Unfortunately, in 2 months, patients presented quite symptomatic worsening dyspnea, ankle edemas. We are now able also to measure his tricuspid regurgitation gradient, which showed pulmonary hypertension. There were other signs, echo signs of congestion. Also, his NT-proBNP increased significantly. His renals worsened. So, of course, our reaction was increase of furosemide dose, but we also realized that this is a problematic patient. So we initiated a telemonitoring system. As I mentioned, it is a certified medical device which uses AI analysis of photoplethysmography in order to track left ventricular filling pressures, based on which we can manage heart failure patients or worsening heart failure patients much more efficiently. And this was also the case with this patient. We were able to keep him 1 year out of any hospitalization. And during that time, we were also trying to correct the cause of his heart failure, which was the severe aortic regurgitation. And finally, after 1 year, we were able to arrange special intervention. It's TAVI, but not with a standard valve, but with a trilogy valve, which is a special prosthesis transcatheter valve that was only recently approved for treating aortic regurgitation. So this patient underwent this procedure in Charité in Berlin, so outside of our country. And here you can see during this 1 year of conservative management, we were able to prevent hospitalizations of these patients, but the filling pressures were usually above 25 millimeters of mercury. Fortunately, he didn't end up in hospital, but of course his quality of life was limited. After the implantation of the trilogy heart valve, this is how the cardiac filling pressures decreased, and during the entire course, he was stable. He's visiting my office now every 6 months, and he is doing very well. Also his laboratory parameters are fine. He's now on furosemide of 40 milligrams. So what are the learning points? Remote hemodynamic monitoring, as we know from randomized clinical trials with implantable devices, improves outcomes. It reduces heart failure hospitalizations, and even in heart failure with reduced ejection fraction, it decreases mortality. However, these implantable devices are very expensive, and of course they require invasive procedure. So this is where our alternative system comes into play. It just uses a simple pulse oximeter, as you can use on the picture. The patients measure their PPG 2 minutes in standing position and 2 minutes in recumbent position every other day. The signal is analyzed via AI, and we can get this track or this graph of his left ventricle filling pressures, and this is only one of many successful clinical cases where this novel telemedical system helped to prevent hospitalizations. If you are interested, you can scan the QR code and you can know more about this solution. And now I'd happy to hear your questions. Thank you.
Thank you very much, Dr. Bohm. It was a very, very nice presentation. I really loved the way in which you used this non-invasive hemodynamic monitor, because we know we could have invasive hemodynamic monitors that, although they are small, they are still an invasive procedure. Here, instead, you can use a simple pulse oximeter, and you take 5 minutes of your time in the morning, every other day, and you can monitor the patient from home. Do you think this also will reduce not just the hospitalization, but also the requirement for outpatient visits? And my next question is this available in my country?
Oh, yeah, good questions. So actually, yesterday I was presenting our first results from the clinical practice. Because right now the solution is available in Slovakia, where it's reimbursed by all health insurances, and also in Germany. We are starting in Germany in a few months, and we got reimbursement by all health insurances. So unless you didn't move to Germany, I guess it's not available in your country. I mean, if you are asking about reimbursement, of course, this is a certified medical device, so it is available in all European countries, but other than Slovakia and Germany, patients have to pay for this. But we are, of course, open to some pilots. And the other question regarding the frequency of the visits. So from our preliminary results, where we monitor patients, 200 patients for half a year, we had in average 10 phone interventions per 100 patients per month. So of course, if you are monitoring these patients, it leads to some phone consults, which then leads to adjustment of the therapy, especially diuretic therapy. But a good thing is that it led only to one ad hoc in-person medical checkup per 100 patients per month. So most of the cases were able to solve by phone consult. So yeah, it adds one additional outpatient checkup per 100 patients per month, which I think is really nice.
Massive. Thank you very much. This is amazing.
Very nice and very promising. But I have a question. Do you have any studies or trials that compare this system with the invasive monitoring?
Yeah, this was of course requirement for obtaining the CE marking, the medical certification. So actually, a few months ago in Serbia, I presented at lay breaker section the results of our validation study, where we validated the solution against right heart catheterization, so against pulmonary artery wedge pressure, and also against echocardiography. And we had excellent discrimination capacity for increased filling pressure and also strong correlation with the pulmonary artery wedge pressure. And based on these results, we also obtained the CE marking, the medical certification. So.
Very nice, thank you. And another practical question. Who is consulting the patients on the phone, the nurses or the doctors?
So the phone consults are done by the nurses, and only if there is a need to adjust the therapy, so this is done by physicians. But many times the patients are non-compliant, or they do some dietary mistakes, some excessive salt and fluid intake, or this kind of stuff. So this is usually solvable by a nurse. But if the condition requires increase of furosemide, for example, or changing uptitrating GDMT, then this is done by a physician.
And do you get like an alarm when there are critical situations, when there are some changes in the patient status, and
Yes.
to intervene in an emergency way?
Yes, absolutely. So there is a dashboard with an alert system, so there is no need to check every measurement. It is powered by really smart AI algorithms. So the first alert goes to nurse, and the nurse has to act only when there is an alert. And if she can't solve the situation, then it is escalated to the physician. But there is an alert system. So it's really quite easy. So one nurse in our case is now monitoring 400 patients, which is more or less the limit, but one nurse can monitor around 350 to 400 patients.
Very nice, thank you.
We do have a question from the audience.
Hi, good afternoon. My name is Valerie Drost from Erasmus University Medical Center Rotterdam. Thank you thank you very much for a very nice presentation. I was wondering at what stage after implantation you start this monitoring. Maybe I missed it. And also, what do you see in the behavior of the patients? Can I imagine that, for example, in the older age group, getting an LVAD in itself is quite already a big intervention and life-changing event, and then you have a lot of lifestyle changes and also like driveline monitoring, etc. What are your experiences in different age groups? Maybe how they deal with this remote monitoring, because they also they need to do something for you. There are a lot of gains, I see that. So congratulations. But yeah, do you see any changes in between patient groups and the age groups, for example?
Yeah, so thank you. Very, very practical question. So this patient, as I mentioned, was 83 years old, and he was able to do all the measurements by himself because it's really easy. He just puts a pulse oximeter on his finger. It is paired with a smartphone app, so this is the only requirement that the patient need to have a smartphone app and a smartphone. If the patient has a smartphone, then it's sure that he will be able to control the app because it's really very easy. So this patient was doing everything alone, and the important thing is that so he was in 1 month hospitalized twice due to pulmonary edema, almost died the second time. So he was really motivated to do something in order to not to stay to go again to the hospital. And when he saw that once he started with this telemonitoring, he was really not acutely decompensated anymore. So although his quality of life wasn't that good because he still had elevated filling pressure because he has really a massive aortic regurgitation and other comorbidities. But he was away of the hospital, and this was so important for him. So he really measured himself every second day. He didn't miss any one measurement, and actually he's very thankful. And we were monitoring him so 1 year before the intervention. So I didn't have the whole graph, but it is here, and this is the drop of the LVFP after the intervention, and for the whole for the entire follow-up, he is now stable. So, but regarding the age doesn't matter that much. I would say that maybe, and this is a bit unfortunate, but more the socioeconomic conditions or circumstances play a role, because still in Slovakia, many patients, even if they are younger, they, for example, don't have a smartphone because they are, I don't know, workers, or they have a standard, phone with buttons. So these people, they can't, do even these easy things like to connect something via Bluetooth with a phone, so on. So I wouldn't say that the age plays the role here, rather the socioeconomic status.
Thank you very much. I think if there are no other questions, I think we...
Thank you.
Oh, we do have a question. You're getting popular, Dr. Bohm.
Congratulations for the presentation. We've been doing some kind of similar clinical trial in Brazil. Send my compliments for your nurse team, because it's a really, really hard work to do. And my question is, did you do voice monitoring or also video monitoring? And then the second question is, you use some kind of instrument, validate instrument, to measure any kind of outcome?
So we are asking if we are using voice monitoring, or you are using voice monitoring?
No. We use voice and video monitoring.
Okay.
My question is, you use voice and video monitoring, or just voice monitoring, and the kind of instruments that you've been using for the quantitative outcomes?
So we use monitoring of photoplethysmography. We don't use voice monitoring. Okay, so that's one thing. So that's why the patient needs a pulse oximeter, because it can record PPG, photoplethysmography, and that's the signal that our AI algorithms are analyzing. And and regarding outcomes, so as I mentioned yesterday, I presented our first outcome study, only preliminary results, 6 months of follow-up, but we are looking for heart failure hospitalizations and that. And we actually were able, it is only a single arm study, but we were able to, this monitoring led or was associated, because we can't say if there was a causality, it's not a randomized clinical trial, but was associated with a reduction of heart failure hospitalizations and that by 70%, which is very nice.
Thank you very much. I think that with this presentation, if there are no other questions, we can close the session. I would really love to thank my co-chair, Irina. It's been very nice seeing you here at the Congress, and please again accept my apologies for the late start. Irina, thank you.
I thank you too for being my co-chair. It was very nice to co-chair with you this wonderful session. I think it was a very interesting and useful, practically useful session. I thank all the audience which were here with us, which were active, and I'm hoping to see you in our session in this Congress and the next ESC Congresses that are about to come. Have a nice and interesting day. Bye-bye.